Aye, okay, good. So yeah, I'm Richard Lowrie. I'm a pharmacist. I work in NHS Greater Glasgow Clyde. My main role is as a reader in the Centre for Homelessness and Inclusion Health in the University of Edinburgh. And this wee spiel is about a kind of large scale definitive randomised controlled trial that's currently running. And a wee bit about the background, a wee bit about the trial itself, and some information hot off the press in relation to the characteristics of the people who are involved in the trial, and some of the kind of soundings from people around reasons for overdose. And I can guarantee that you will get new information in this presentation that's not been aired before. So hopefully you'll leave with a wee bit more savvy about this area than you did previously. So the Phoenix team, Phoenix is an acronym. It's pharmacist. It also involves nurses and the odd GP. Pharmacist, homeless, outreach, engagement, and non-medical independent prescribing. It's a team of people who are committed to try and improve outcomes for folk who are homeless and face other severe disadvantages. And the trial itself that I'm going to be talking about is based in 6 different settings across Scotland. Those are the settings that I've got in the slide in the front. Can you see that okay, Anna? Yeah.
Yeah, no problem. We're on the Phoenix team slide. Page. Is that the one you want to be on? Excellent.
Yep. So Grampian, NHS Lanarkshire, Lothian, Highland, Ayrshire, Nairn, and Tayside. Those are the 6 settings. Some settings we approached, they didn't want to be involved. I've got the kind of the third sector teams in each of the settings in red highlight there, because that's the nub of what we're trying to do. It's about engagement with people who are homeless, with other disadvantages, and then bringing in the NHS clinicians to try and support people's medical care at the same time, based on that bridge provided by these 6 organisations in these 6 areas. ADA's alcohol and drugs programme in Aberdeen, Turning Point Scotland, Streetwork, it's also Simon Community, New Start Highland, the organisation in Inverness, and the ADP are involved in Ayrshire, Nairn, and in BD it's the parish nurses at the Steeple Church. Okay, there's also a wider team involved in the clinical trials unit. You have to have a clinical trials unit involved in any kind of randomised controlled trial. And obviously Centre for Homelessness and Inclusion Health, my colleague Sarah Johnston's leading up the qualitative parts. We've got folk from the Usher Institute, Bruce Guthrie and Stuart Mercer, and the chair of the steering groups from Hannipin, which is in Minnesota. Her name's Kate Vickery. So moving on, this is the plan for the next maybe 20 minutes. I'll cover the background to the study. I'll talk about participant recruitment. I'll then move on to baseline results from in-person assessments. So these are assessments that have been conducted by researchers who are third sector researchers in the whole, sitting down with people wherever they may be, whether that's in the street, in their accommodation, or in kind of low threshold hubs. And they've collected information before they've randomised people to active or control. And at the same time, they've asked about reasons for overdose, and I want to share those things with you today. First of all, the background then. I mean, this is the reason why I certainly get involved in this research, and it's the reason why most of the collaborators are involved in it as well. In fact, pretty much all of them. We're really keen to try and make a difference through research to demonstrate, how we can improve things. You get these kind of scenes quite a lot when you work in homelessness. If you go to where people live. And James's a classic example. You're crunching over needles and syringes and used gear in a place that's really not fit for habitation. And so this is the way it is for people who are homeless in a lot of areas in Scotland. And it's not acceptable because, mortality and morbidity flows from your living conditions. So we try and make it better. If you ask Jamesy and any others of this type, how they're doing and what their background is, you get a kind of similar picture to the situation we've had for the last maybe 10, 20 years, that they've been homeless for a long time, cycling in and out of jail, quite often fleeing violence, victims or perpetrators of, and, you know, living in temporary accommodation, struggling with the digitisation of welfare systems, so that benefits are kind of a feast or a famine, mostly a famine. Medical history, quite common for Jamesy there, you know, talking about leg ulcers, secondary to injecting drug use, struggling to sleep, as you would if you were staying in a hostel that's very noisy. PTSD is quite common as well, mental health problems, pain, prevalence of pain is really high in this population. And obviously if you're living in ultra-processed snacks for a long time, then you're likely to be obese. It's not so much malnourishment. People are homeless in Scotland, it's more obesity because of the high density, high calorie snacks. And respiratory problems are common. Smoking is something that people have been doing since maybe early teens. So, you know, premature aging in terms of how the lung function is, and lots of other issues as well. Multiple previous overdoses, you know. Drug use, quite common, and maybe 70 to 80% of people are homeless. And the folk that we've recruited for this study, all are currently using or have previously overdosed. They are all homeless and they all have criminal histories. Okay, and we've gone for that group because this group is probably at highest risk of subsequent overdose and drug death in Scotland. The treatment that we currently see for folk like this with multiple competing priorities is pretty basic, you know, methadone. Dose varies a lot, of course, and also, you know, an antidepressant. That this guy wasn't receiving anything else other than that on any kind of regular basis. And so there's a real challenge to try and improve things for this group. I suppose the question I would ask there is that, you know, when you're looking to try and engage with folk who are struggling with all these health and wider social problems, your first challenge is to try and find them. And actually that's not difficult. It's a myth that these folk are hard to reach or missing. It's a myth. What we found is that if you work with third sector teams locally, you're able to engage with these guys relatively easily, you know, and repeatedly. And this particular street here is where I started working in homelessness about 20 years ago, probably over that actually. If you carry on along Midland Street on the right hand side, there's a place called the Wayside Centre, and it's typical of kind of low threshold venues where folk who are homeless tend to go for something to eat and a bit of conversation and a bit of safety, and sometimes, if you're lucky, medical help as well. So I worked in there for a while. It's a Catholic lay organisation who've provided care 365 days a year for the last 30, 40 years, you know. So these places are like, you know, like heaven for folk who are homeless, looking for a bit of support. Inside, you'll see quite often in this place and elsewhere, you know, amenities for people to have a wash, conversation, as I say, and something to eat, you know, and referral onwards to other services. When you ask folk about who's best placed to help them, you rarely hear about, you know, the health service, healthcare professionals. As it happens, you mostly hear about, you know, stories to do with folk from third sector who've gone way beyond the usual realms of commitment to engage with them repeatedly and to do things for them, and that's been the case when we've gone around Scotland when we've asked folk about that. So I guess you've read that, okay. So I guess the idea is that we're creating an intervention here based on what people say works and based on what people's needs are, whether that's expressed or as a result of kind of the engagement or lack of engagement with primary care and increased engagement with secondary care. And so what we've done is we've crafted an intervention based on what people say works, and we've involved third sector, local third sector, and we've partnered third sector workers on outreach with an NHS clinician, whether that's a pharmacist, that's the way it originally worked with us, or a nurse, or you know, GPs whenever you can. And you've got these guys going out and about to engage and hopefully to assess the person's issues repeatedly, seeing them maybe once a week, continuously, and linking them in with all the various services, you know. So it's not rocket science, it's courtesy really to take services to people. Something that's been done in different realms over the years, but we're trying to nail this through a kind of definite kind of partnership model that's integrated fully with health and third sector organisations locally. And the idea is to see whether it works, you know, so we're looking to try and reduce the occurrence of fatal or non-fatal overdose, because that's probably the biggest challenge for this group in terms of risks to early death. And the reason for that is because we know that drug use is very common, and probably about 40% of people who are homeless die a drug death, which is something that, you know, we shouldn't just accept. We should try and change, and that's why we're doing this project. And it's a complicated project because the people we're trying to support here have got complex needs, and complex needs merit a complex intervention, meaning something that's got lots of different parts that move at the same time and involve different people, and it varies in terms of what support you provide and how you provide it. And suffice it to say that these papers I've just put up on the screen just now are all the kind of pilot work that we've done. And there's a lot more, particularly in relation to qualitative stuff that I've not put on the screen here. But these are the main studies that we used to develop the kind of mapping and modelling of the intervention. That's the first one there. And then subsequently we did a pilot randomised controlled trial in accordance with the MRC framework for complex interventions. And then we did another one, another pilot randomised controlled trial, multi-centre. And what that showed in totality is that, you know, you can identify people who are severely disadvantaged, you can engage them in research, you can collect information, you can follow them up, you can deliver an intervention, and there's a signal that we can improve their quality of life, and there's a signal that we can delay the time to overdose for as long as we support them through an intervention called Phoenix. And so the next step to that was a grant application for a definitive randomised controlled trial. Apologies, this is a wee bit blurred, but this is the description of that definitive randomised controlled trial, and that's what I'm talking about here just now. Okay, so the protocol for it's out there, and you know, describes things in chapter and verse, and what I'm describing here just now is the study itself, which is ongoing. And so this is the idea, you know, this is the idea within a randomised controlled trial, and in this case it's a definitive one, so it's powered to detect a primary outcome of, you know, time to a fatal or non-fatal overdose. And this wee kind of chart I've got here gives you an idea of the progress and the timelines involved. So between January and June 2025, we'd recruited all of the researchers in all the areas I mentioned at the beginning, 6 areas of Scotland. And we had gone out to the streets and to graveyards and to everywhere else to try and recruit folk who are furthest from care and need a bit of support. And when we recruited, we then collected baseline data, okay, data when you speak to the person about all kinds of issues. And then we randomised folk to either usual care or the intervention on top of usual care. We didn't take anything away. We made sure that what we were providing is an addition to what folk usually get. And those were the expected numbers. You know, we expected to randomise 196 to each group and then follow up after 9 months, okay, after delivering the intervention between January 25 and March 26. Okay, so clearly we're right in the throes of it just now. There's a parallel qualitative process and economic evaluation running alongside, because if you provide evidence these days, as most of you probably know, of benefit, if you improve quality of life, if you delay time to overdose or whatever it may be, you also need to know that the model, the intervention you're describing is implementable and acceptable to folk. That's the qualitative process evaluation, that's the aim. And you also need to know whether it's cost effective. So the idea is that we plan to recruit 378 participants across those 6 settings. The outcomes there, quickly, the primary is to reduce the occurrence of fatal or non-fatal overdose. I've mentioned that already. That's self-reported and also confirmed through ambulance call-outs and hospital visits and all kinds of other sources of information. Okay. And we've got secondary outcomes which reflect what we found in the pilot to be, you know, the kind of things that we can have an impact on. So that was the background. In terms of recruitment, how are we doing? And this, I guess, is one of the areas where most trials falter in this particular group. But because we've got the support of the third sector, and we know most of the participants locally, this has been made a lot easier, you know. So the target was 378. As I say, we've gone on outreach with the backpacks and the consent forms to get things moving in that direction. And we've in total recruited 393 people so far and randomised those. So we're doing fine there. In terms of baseline results, moving on to that. So what I want to tell you then is summary measures of the things that we collected from those 393 people. Okay, not got a lot of time to go through this information. I can share these slides afterwards. This information hasn't been published yet, so it's not gone through peer review. It's likely to have several iterations until it does that. These are the raw figures. They might be tweaked slightly when we look at it with the stats team and we go around in circles a wee bit. There's always things that change slightly before you get it publication. But suffice it to say that, you know, there's a few things that jump out here. Stuff like no structured activity. You know, people tell us, you know, they're really keen to do things during the day, but they don't have the opportunities to. And if you do things during the day and there's some kind of structure, it's likely that you can become healthier and avoid certainly drug use, you know, when you've got a purpose to the day, other than, you know, just being in your hostel. Lots of these folks have children. That really has implications for things down the line and something that we should take notice of and maybe try and address. Most of them, to be honest, don't have access to their children. So there's a real issue around there about, you know, a cycle of, you know, being in care and becoming homeless that we need to break somehow. And a lot were in care as a child. Other summary measures, interesting to note that folk changed accommodation on average 3 times in the kind of year prior to baseline. And that causes havoc in terms of GP registration, in terms of, you know, getting your benefits, and in terms of people knowing where you are and building up relationships and getting on with your life. So lots of things in there. Also important to know we recruited 14%. 14% of participants we recruited, I should say, are folk who are rough sleeping. So we didn't just go for folk who were easier to engage because of living in hostels, for example. Baseline characteristics also include near patient assessments by the researchers, and what these data on this table show you is that, you know, we've got quite a serious problem with COPD, despite folk being maybe 42, 43 years old on average, and a lung age of 81 years equivalent. Lots of fractures, lots of head injuries, and pain is prevalent. And all of these things together are worse than any of them in isolation, as you know, and we've got, you know, maybe an average 5 or 6 physical health problems per participant. So there's a challenge there in terms of managing that. Mental health problems, similar, lots of different types, and also, you know, combined. So on average, people had 4, standard deviation of 2, SD2, 4 mental health problems per participant. Now this is self-report. We are also collecting baseline data from GP practices and alcohol and drug recovery services, Scottish Ambulance Service, prisons, and the police. Those data have yet to come in. We'll be getting them soon, and they'll enrich what we know already and what I'm just describing here in this PowerPoint. But to cut a long story short, we've got people who have multiple physical health problems, multiple mental health problems, and polydrug use. The polydrug use is characterised by, you know, the things that I guess a lot of you know about, you know, concurrent use of heroin, cocaine, and street benzos. Gabapentin as well, 100%. 392 people said they were using gabapentin, which is incredible. And so on average, you know, people 3.8, 4 street drugs per person, with an average of 3 overdoses in the last year or so. So yeah, I mean, these are the stats. These are the kind of things that we need to know about in order that we can then try and do something about them. For this really challenging situation. We've got folk who are homeless, dying all the time in Scotland, you know, from overdose. So the drug use continues. Most are on OST, opiate substitution treatment, but not all. Some way to go there. These figures are difficult to achieve, difficult to report otherwise through linked administrative data. You really have to go and ask folk, and that's what we've done here. Most folk are GP registered, but whether they engage with that GP is another story altogether. And so, in summary, what we've got is that, you know, people with highest risk of overdose in Scotland and drug death have got mostly untreated physical health problems, untreated mental health problems too. Take a lot of drugs and overdose 2 or 3 times a year, and so with a mountain to climb. We asked, as part of this work, and this is new information hot off the press, we asked people during interviews, you know, and this study and 2 previous studies that I've been involved in, 2 of the pilot studies. We asked whether the person knew about the triggers for their overdose, you know, what were the reasons for the overdose, not the drug itself, not a combination of drugs. We asked that simple question in the context of the baseline assessments. 42 people didn't respond, 478 did. Because the question, we didn't put it right, we should have worked harder to make that understandable. 107 folk just gave us the names of the drugs that they overdosed with rather than the reasons, the triggers for overdose in the first place, if you see what I mean. But 371 people told us during the in-person assessments the reasons why they overdosed. So they knew about the triggers, and quite a few gave us multiple reasons. And what I'm going to show now is a brief summary of categories of overdose triggers in this population. Okay, so the column on the left gives us overdose triggers, categorized, themes if you like, and the column in the middle is an example, or one or more examples of the kind of quotes that we got from folk within these various kind of trigger themes. And as you're reading that, I'm thinking to myself, right, I wonder whether you can have a guess about which of these was the most prevalent in terms of the theme. You know, what did people say was the most common reason for them overdosing? And so I've given in the third column a couple of the percentages. So this is a percentage of the reasons, okay, not of the number of people, but it's similar. In terms of, you know, overdose being accidental, just about 10% didn't mean it, and it just happened because of supply inconsistencies, for example. And again, you know, less than 10% were unsure. In terms of the rest, the percentages for the rest, when I'm clicking this, it's filtering in the kind of low percentages of reasons for these themes. In case anybody doesn't know, gallus there on the left-hand side is a word that we use in Glasgow for no caring, just going ahead and doing it, you know, brazen. So less than 3% of people gave kind of gallus reasons for overdosing. Again, less than 3% said it was down to the living conditions, whether that's sleeping rough or in a B&B that wasn't really suitable for them. Very few down the bottom there said the reason for it was suboptimal prescription. Okay, so not enough drugs, not enough diazepam or prescribed, or not enough OST. Very, very few of these folk who are the ones who overdose continuously in Scotland and are at highest risk of drug death said it was anything to do with their prescription. Instead, you had some folk saying, yeah, they enjoyed you know, the whole drug use situation, they accepted that. Grief was a big factor for maybe 6% of folk. Very few, in relative terms, said that it was intentional or planned. Okay, this tells you that the majority don't want to overdose and need help to prevent it. Relationships are key. 1 in 10 said it was because of bad relationships as a result of splitting with your partner, for example. They went on to overdose shortly afterwards. And as you can guess, the 3 at the top were the most common responses, with 12% saying that they use the overdose to block trauma, previous trauma, unresolved adverse experiences or ongoing adverse experiences. Quite a lot of folk, mental health issues, or physical health problems were overwhelming, and the highest percentage of people who gave the reason was just being an addict. You know, that's people's own words. I don't like that word, but that's what people told us. It's just being an addict. It's just part and parcel of it. You know, hopelessness, alienation, anomie is probably a word that I would use to describe that this kind of category. So people just accepted it, and I don't think that's something that we should accept, and that's why we're doing this work. So the summary then of what I've said so far, I've mentioned this before, and also to add that people who are highest risk of drug death in Scotland know why they overdose, and I think it's maybe time that we try and challenge that status quo, unacceptable status quo. We need to challenge that, you know, through different types of working, and maybe Phoenix can do it, but maybe it can't. But if it can't, then at least we've tried, and we expect the full results around about December 2027. Thanks very much.
Great, thank you, Richard. Fascinating. Dig in. So basically, you did it better in time. You finished several minutes early, in fact. So we have a lot of time. I see a lot of hands clapping, and people are obviously. Oh, Richard, can you stop sharing your screen? Actually, there we go. Excellent. I was like, I can see myself. That's weird. So let's start with asking people to raise their hands if they want to come in. If you don't feel comfortable talking in such a big group, please feel free to write in the. Here we go, Agnes. Just feel free to write in the chat function. So, but Agnes, would you like to come in?
Yeah, there's another side to that we see in homelessness is families with their son or daughter that's homeless, and they're called couch surfers, and it makes it very, very difficult for them to access the bidding system to get a house, because they're digitally excluded when they might not have a device. They might be in a house where there's no internet, or they might just not be in a frame of mind, or they can't keep an appointment system. Of course, if they've been sleeping somewhere that they're not used to and they don't know there'll be there been problems or triggers the night before, they're never going to waking up and go, oh, 11 o'clock, I better go and try and bid. So we raised a discrimination, our family group in Inverclyde, to the housing associations, and they said that they would put unintentional discrimination, I pointed to it, and they said they were going to take more time to invite them in or go out to them and support them during the bidding system, and at least it's a step forward. But what happens is the mother or the family, when they're couch surfing, are now left to deal with them, just what you were talking about there, Richard, with the health issues. Sorry, the endometriosis, conditions that gallbladder, everything, conditions that they never had while they were on drugs. And now it's all left to the families to do that, and I feel that support is just not there. And it's really, all of a sudden they've been in the throes of addiction, the mother and the daughter, and now before, during, and now after in recovery, no house, can't see her children, the health issues, and the system's just, it's a joke for them. And that's the ripple in the families, and through groups like us supporting the families, helping them to support their loved ones and speaking up, find our voices, just like we raised the discrimination here in Inverclyde. But it's not easy. Not easy for them to find their life again, to get a house. And I also raised a point from the Buzz magazine, when one of the people were in it, he was homeless. He said he would rather have been homeless as living in what they were offering him. But then he met somebody within the services, just what Richard said, somebody that goes to that extra mile, and they delivered a service in a peer support role, and it made all the difference. So we need to look at the services, Richard, Anna.
Thank you, Agnes, for your contribution. I don't know if you wanted to, it wasn't really so much a question, but just putting your experience across. It's really powerful. Thank you. I'm going to bring John in.
Yeah, many thanks, Hannah, and thanks, Richard. A really compelling and presentation on such an important area. The most striking jump-out finding for me was that only 10% of overdoses being accidental, and it just flags up the question of suicidal intent. We know that that's under-investigated and hugely under-ascertained, and it just raises the question: should we be joining the kind of multidisciplinary review processes for drug-related deaths that occur alongside suicidal investigations as well? Does there need to be a much more mainstream recognition of that? Because I think it's hugely underappreciated. There's an assumption that this is that most are accidental when it's clearly not the case for this subgroup. Thanks.
Yep.
Do you want to come back to that, Mike, Richard, or I'm not sure if there was
a good point. I agree with you, John.
It's a good point.
Absolutely. Yep.
Yep. Great. Michael, if you want to come in.
Hi, Richard. That was a really nice presentation, and thank you very much. We're looking forward to hearing what your trial is doing. There's a couple, just to follow on from John's comment, there's some really nice data coming out of Sydney now, where they've prospectively looked at people who present with hospital either with self-harm or with unintentional overdoses, and look what happens to them over the next few years. And there's a really high rate of deaths from patients who present with what was clearly an unintentional overdose from self-harm later on. So these groups are really intertwined and overlooked. And as you say, in the hospital, we often don't get a psychiatric review for patients who present with what's perceived to be unintentional, and perhaps we should be exploring that more deeply. I was quite struck by your comment about gabapentin, because pregabalin is supposed to be more common. We're doing a study at the moment with Rufus where we take blood samples from the patients coming in with unintentional overdoses. We are finding pregabalin there more than gabapentin. So it's interesting that, were you saying 100% of patients were on gabapentinoids, including pregabalin and gabapentin, or are they all specifically on gabapentin?
Either or, Michael.
Yeah, either or. Okay, so it's gabapentinoids is that thing. Okay, thanks a lot.
Great. Is that everything, Michael? Or yeah.
Oh, there's lots more,
Charlotte.
but no, it's fascinating. Thank you.
Fair enough. Well, we might bring you in later if there's nobody else to ask questions. Charlotte, if you'd like to come in.
Just making sure my kit's turning on. Thank you so much for the amazing presentation. I'm sure everyone's saying that was really informative, especially the different percentages of the reasons behind overdose. It's sort of chiming in with my experience and wondering if there's something in the future that could be looked at as well. A lot of the time when my team are working with those who are homeless, we're also working with people who are in temporary accommodation in hotels, B&Bs, that sort of thing. And we find, especially with those who are living with alcohol addiction, huge issues in terms of how to manage their treatment, because a lot of the time they're being put into B&Bs over the top of pubs or opposite pubs, so they're constantly surrounded by drinking. If this is a person who's in need of a detox, you can't really do a community detox in a hotel because it's not a safe environment, so they have to be taken out and detoxed in an inpatient facility, meaning they actually lose their room in the hotel and have to go back to applying again. And then it's the management of, okay, so if we do manage to detox this person, get them back into this environment, whether because they haven't wanted to go to rehab or something like that, how do we then help them maintain this new sobriety? Because we effectively put them back into an environment where, okay, we've taken the alcohol off you, brilliant, we're going to keep working with you, but go back to this pub and be surrounded by booze and other people who are drinking or offering you drugs, that sort of thing. And it's like, it's this self-fulfilling prophecy that these people come to us for help, we try and help, but at the same time, other factors, whether they've got all this support going in, it's going to be super hard for them to be able to actually maintain this if they're surrounded by other people who are also struggling with this issue as well. And it's that thing of, in the future, when we're looking at homelessness, is there have to be some sort of thing taken into account of where to put people who are working with services for substance use issues, so that we can help support them, so we're not creating this ongoing vicious cycle of you're homeless with a substance issue, but we can't do anything about where you go because we have a housing crisis, so sorry, you'd have to go where you want to. And I know it's a bit sort of pie in the sky. Imagine if we could just build a facility. I'd love that. Yes, let's do that. But does anyone else have the same experiences of almost treading water rather than treatment? And it feels really unfair that just because this person's in a situation in their life where they haven't got their own place, they can't access the level of treatment that we feel they deserve and we want to give them because the resources just aren't there. Thank you for coming to my TED Talk.
Thanks, Charlotte. I'll bring in Ryan, because there wasn't necessarily a question there, but yes, experiences are very much, you know, important here as well. So Ryan, would you like to come in?
Yeah, it was just a comment on from what Charlotte just said there. So most of my experience was down in South England, and I think we're limited on the resources that we've got up here. We would have so-called dry hostels and wet hostels for that reason. You know, so most major city has got at least one hostel for people who have post-detox, and they're as strict as they can be to make sure that there are no substances or alcohol in the premises. Do we not have anything like that in Scotland, in Glasgow and Edinburgh?
Richard?
I think there is, aye. There's some places like that, right?
So, I mean,
Okay.
I know it's difficult, but I was just trying to answer Charlotte's issue there of somebody coming out of detox and then putting them straight back into the lion's den, as it were. You know, if there are so-called dry detoxes, then I think that's something that during the detox process, the workers in either the rehab or the detox need to look at that and be mindful of that, and maybe have that as a part of the plan for day one, the unsuccessful completion of detox. That, you know, within reason, and, you know, like you're saying, in a perfect world, we'd have all these buildings, but, you know, just to try and utilise these resources if we can, and keeping that in mind for day one. It was just a comment I wanted to make, guys. Thank you.
No, I appreciate that, Ryan, and I know what you're talking about there as well. One thing I would say is that a lot of that stuff and the experience I've got is out with reach, you know. I can't really influence it in terms of rehab beds. It's been the situation for a long while. And somewhere suitable for people to go, you know, in housing first, and you know, temporary furnished flats that are actually furnished, and the people are supported within them. I just don't see that that's a future we can sustain because of the cost and because of the absence of the buildings and the way the whole system is. So I suppose what we're trying to do through this work is to try and maximise and optimise what we've got control of, which is, you know, support through the health service and support through third sector, both together at the same time and continuous. Maybe that will work, maybe it will no, but we need to give it a try then. You know?
Yeah, absolutely. So have we started to implement housing first up here? Because that's actually something that I started down in Southampton.
Aye, it's implemented up here.
The
extent of it varies across different areas. And,
it depends on council housing stock and all that.
It has been implemented, but it's also been removed as well. Like down in the borders, we had housing first, and now they've just lost their funding. So, yeah, so it's ins and outs. I'm just conscious of time, and we have 3 more commentaries or questions, so I'm going to move on. But thank you, Ryan, for your commentary there.
Welcome.
Mark, if you'd like to come in.
Thanks, Anna. Yeah, thanks. Fantastic presentation. Yeah, it's a bit of a public health observation, really. I've been involved in ongoing research for many, many years, as some of you know, and I don't know if you recall some years ago, and I apologise if it's a pejorative term, but when the Glasgow effect started doing the rounds in public health, and you know, a boy born in certain parts of Glasgow would have a better life chance in Basra or North Korea, and then there was a 3-city study comparing Manchester, Glasgow and Liverpool, and still the health discrepancy was quite marked. I wonder whether that would be the case if we were to repeat that now, because I'm currently doing some intensive ethnographic stuff in Burnley, in East Lancashire, and I'm quite familiar with parts of Glasgow, and it seems ever more similar than it ever was. And one of the thing, and it's interesting that you picked up on places like churches, because one place where I've had constant access to people is in a place called Church on the Street, which is fascinating. But, and this, I'm not complaining, I'm just an observation, they don't get any funding, but yet the official providers and commissioners think nothing of spending £70,000 on 2 outreach workers to go into that place to take people back to a service that they don't want. Yeah, so a fantastic presentation. Thank you so much.
Thanks.
Thanks, Mark. Alan, if you'd like to come in. You're muted.
Yes, thank you. I would just like to thank Richard first for a great presentation. But I was going back to what Ryan was saying. In Aberdeen, we've got a wet house, and it's run by the Cyrenians, where people can live in the house, but they're supervised over their alcohol intake, and that helps them to get off their addiction. And yes, it's been running for a few years now. So I think it's got about 20 rooms, I think. I'm sure it has. So I would and another point I was going to ask Richard, I noticed in your figures, the sex, it was male. Was there any females involved in it? Yeah.
Aye, they were. That's just a way that we use in describing things in tables. So it's a wee bit old-fashioned, I know, appreciate. So we just have gender % males. The rest are females, but of course there's some trans folk as well now, you know. And that was in the kind of small type, but I didn't really have the space to include that. But yeah, includes females, yeah, 20-30%, I think.
Okay.
Good. Thank you.
Thanks, Alan. Michael, in you come.
So there was a quick pause, so I put a question in. So you haven't talked about, I mean, it's really, really valuable to work out the data, to look at the results. How much cost effectiveness are you doing, and how easy is it to find people like you who are willing to go out and do this kind of engagement in the future? If we're going to make this Scotland-wide, is it doable because people want to do it, and how much will it cost? Do you have any sense? I mean, are you doing cost effectiveness in your analysis?
Yeah, so thanks, Michael. The first thing is to know whether or not it works. I'm not too bothered about cost effectiveness. If the findings are neutral or negative, we don't know. That's true, the adventure of a randomised
but if it does
trial,
work,
you know?
and you haven't taken the data, then you won't know whether it's going to be affordable.
If the randomised controlled trial shows that we have an intervention here which impacts, for the first time, as far as I know, drug deaths in Scotland or elsewhere through this type of intervention, then we have a parallel economic evaluation running alongside it, and we have a guy in the health economics unit, the clinical trials unit in Edinburgh, running that, Andrew Stoddart, and it's a full cost effectiveness analysis looking at the impact on individuals, on the NHS, and in social care.
Wonderful. Excellent.
And do you think it's going to be sustainable? Will there be people keen to do this kind of intervention in the future? Do you think you're confident that you can?
Yeah, I'm confident, yeah. I mean, I think there'll be enough pharmacists to do it. I think there'll be enough nurses who want to do it. There'll be enough GPs who want to do it. There'll be pharmacy technicians who are a new kind of a group of people who are available to do this and have got the right mindset and have got the right focus. But it's not about those guys. It's mostly about the third sector who've got the relationships already, Michael, because as you know, if you don't have that relationship with somebody or you don't build on that, then you will not really affect any kind of change over the long term.
No, it's fantastic. Thank you.
Great, thanks, Michael. Aileen, if you'd like to come in.
Hi, Anna. Good to see you.
Hi.
Great to organise this. And thanks, Richard. That was really fantastic, but chilling at the extent of need within the population. So I had conducted with NHS Highland a retrospective study of young people who had died from overdose, and just this similarity in the characteristics of the group that it matches completely perfectly. So, you know, the high proportion of people who've been in care, which is a real issue in Scotland, the criminal justice system being the kind of one system that stuck to them, but wasn't very helpful for them. But one of the findings that we had was that the services who interacted, so they had a lot of interaction with various people, particularly criminal justice, but also addiction services, was because they were young, so these were under 25 and they, you know, ranged from 18 upwards. The focus was always on, in the interactions, the focus was always on moving people into recovery, into some abstinence, whether it was their drinking or their drug use. And they, rather than, now we didn't have the opportunity to interview the people like you have because they were dead, but you could see through the notes that nobody was asking them about supporting them, you know, that idea of supporting people where they are. So it was all the focus was on abstinence and reducing their use rather than tackling. They all had extreme health conditions, mental health conditions, and really struggled to get any support for that. So I wondered in the work you were doing whether you had noted that, but it's really interesting that what you're providing is that general kind of care for people. And I think the really important, that relational care with people who can work with them as human beings, you know, and show care and empathy for them. So I think it'd be fascinating to see the outcome. But I'm just interested if, the other question was, why wasn't Glasgow included? So just from the home turf of Glasgow, curious about that. Thanks.
So thanks very much, Aileen. Your first point there, I mean, I guess what we're trying to do is to work on an individual basis. You know, when we have somebody from the NHS and third sector going to see somebody wherever they are, we stick to them best we can. We try and personalise whatever it is we produce, so we don't go with an agenda to say, right, it's time for recovery. We ask the person what it is important, and we work with them at their pace and their priorities. And sometimes that's about making sure that they get to the dentist to fix their teeth. And if that's the priority, that's fine. And the rest we can do after we address that particular thing, you know. So it's personalised, and we hope that works. How else can we do it? I'm not in their shoes, Aileen, you know. I need to ask folk what's important. It's a courtesy, you know. So we take whatever the priority is there. And the second question there, why is Glasgow not involved? So I'm still asking myself that question. I don't know the answer, Aileen. I've asked. I tried really hard to get Glasgow involved. I'm Glaswegian, probably noticed. It was really important to us to involve the pilot was in Glasgow. In fact, 2 pilots were in Glasgow, and the service we started was in Glasgow. But around about the time when we were launching this study, the homeless health service, specialist homeless health service in Glasgow, was closed, and that had a lot to do with it.
Interesting. Yeah. Thanks. Yeah.
Thanks. That's everyone. I had a wee question, if that's all right, Richard. And it was just, I was fascinated by one of the findings there about the unstructured days and the fact that people were saying that they didn't have any structure. And I was wondering whether or not, I mean, obviously you're in the early stages, but whether or not you've linked into any other sort of research. Certainly I know in the School of Health we have Marissa de Andrade, who's doing the realities in healthcare. And one of the aspects of those is to set up these community hubs, which are to be low threshold spaces that people can access. And I was just wondering if you could just talk very briefly into this finding of needing more structure in their day, and if you've had any thoughts around that at all.
Yeah, lots of thoughts, Anna. Sometimes that's a thing that's missing for people, you know, but it's maybe not so much the structure as the relationships that provide that structure. And what's already there just now are these low threshold community hubs you're talking about. In Edinburgh, Street Work Hub, the staff there are excellent, as the staff are excellent in Inverness and in Aberdeen, Ayrshire and Nairn, in Lanarkshire, and Dundee. You know, these hubs are there already, and I think we need to make more of them. We need to invest more in these places. We need to make sure there's continuity of contracts and the staff are there for a longer period of time because they're excellent, and they're the reason why we're able to recruit this number of people and support them. I think it's therefore more about using what's already there in terms of established relationships and structures and organisations rather than inventing something new, you know.
Yeah, very exciting. Now we have 5 minutes. If anyone wanted to jump in briefly, I'll just have a quick. Here we've got Alexandra says, for the question regarding whether this is a cost-effective approach, the consequences of not addressing health inequality are massive on both personal and societal level. Outreach work is a hugely important approach and helps rebuild bridges with people who have historically had poor experience with the NHS and have been marginalised, and allow for preventative healthcare. Thank you. Yeah, no, that's fine. I think, Aileen, in you come.
It was just one of the many interesting bits that you presented was about the percentage that were unemployed before they came home. That really struck me. So 70% were in employment before they came homeless, because, you know, the way the homeless population is framed by our politicians and in policy is always about, you know, the kind of scroungers on the state. Of course, they're not accessing benefits, so they're not, you couldn't even put them in that category, awful as it is. But that's really interesting that many people, so it really suggests to me a failing the housing system, but I don't know if you have any other data on that to explain that.
Yeah, I mean, I suppose the guys that we're working with, Aileen, I'm sure you know, they can't see the wood for the trees right now, you know, and there are so many overwhelming problems. And I guess what we're trying to do is support people, you know, to work with them, to address their health problems with them, to address their social problems with them, whatever the priorities are. That's the idea, you know. I don't know the answer, but I'm hoping that we can at least improve some of the aspects of their lives through this work. We'll find out around about December time.
But yeah, I suppose it was more so that how people can so quickly fall into homelessness from, you know, being employed when you'd imagine would have the funding. So it, you know, it may indicate problems with the housing policy rather than the individuals themselves. Just it was interesting. Thank you.
Sure.
Thank you. Right, well, I'm picking up that folks, you know, need to get going to the next meetings and all of that kind of stuff. We've had a wonderful turnout, 191 at the peak. Thank you so much for everyone. Richard, do you have any last final words you'd like to pass on? No.
Thanks for the opportunity.
Well, I think we'd all give you a round of applause, and really, really grateful for you coming on here. And, you know, all being well and we continue for another year, we could maybe get you back at some point to get some more findings, because it's fascinating. So, yeah, wonderful. Thank you.
All right.
Okay.
Thanks.
So we shall see you.